everyone, I am Dr. Neha Choudhary. I am a breast consultant surgeon at Narayana Superspeciality Hospital, Howrah and Rabindranath Tagore Institute, Mukundpur, Kolkata. I deal with mainly breast cancer, and this video is especially for all my dear patients. They usually have a lot of questions when they are planned for surgery, and it is difficult to answer all the queries in the OPD even though we try our best. This is an additional video for you to have a quick look. Regarding breast cancer surgery can be offered to you at two stages of your treatment. The first is if you are planning an upfront surgery, as in the surgery is planned first before chemo or radiation. And the second would be if you are planning the surgery after chemotherapy. Okay. Again, breast cancer surgery commonly are of two types: breast conservation surgery or mastectomy. In breast conservation surgery, what we do is we just take the lump out with a little bit of margin, and whatever defect has been created, we try to fill it back with either local breast tissue, which we call as breast oncoplasty, or if the defect is a little bit big, then we might have to bring in tissue from back or from your abdomen, which we call as a flap surgery. Sometimes we can also use some kind of pedicle flaps or some kind of special flaps, and we can always discuss about it. Regarding mastectomy means the whole breast is to be removed, which we do need to offer in certain cases. Whenever we offer mastectomy, you always have the option of doing a whole breast reconstruction, that is remaking a new breast using either your own body tissues or putting an implant. Own body tissue, you can take tissue from the abdomen, that is from your tummy, or from the back or thigh. Usually for these procedures we involve a plastic surgeon, and it is very important that you understand exactly what will happen from your plastic surgeon also, how it will look in the end, what will be the scar, where will be what will be visible. That is very important. Now, so the most important part is you have a very good clarity of what surgery you are going to undergo and what the end result will be. This should be very clear to you. Second part of any breast cancer surgery is staging the axilla. Axilla, as in the armpit, there are small glands that we call as lymph nodes, and it is very important to take a few of them out and check whether the cancer has spread to them, because if the cancer has spread to one or two, then we might have to remove all the axillary nodes. And how do we check which few nodes? What we call it as a sentinel lymph node biopsy. So a sentinel lymph node biopsy is usually offered to those patients who are clinically node negative, that is by clinical examination or any kind of radiology, ultrasound or MR, we are not able to see any suspicious involved nodes in the axilla. In those patients, we do sentinel lymph node biopsy. How we do it usually is we put a little bit of dye in the breast, and then we follow that dye, the blue color lymphatics, to take out the important the nodes which are blue or the nodes which are fluorescent. And we send it for pathology right then and there. In the pathology department, they do something which is known as frozen section, and by frozen section, doing that, they can tell us whether the nodes are involved or not. If the nodes are involved, we usually proceed for an axillary dissection. These days, some cases we can avoid it, but overall we do an axillary clearance in these cases. If they are negative, we don't do any further surgery. When we plan a patient for axillary surgery or axillary lymph node dissection, these are usually cases who are already known node positive or node suspicious, like on clinical examination or on radiology, we know that the node is already positive or it is very highly suspicious. Or we have a FNAC report of a positive node. So after an axillary surgery, because if you are doing an axillary lymph node dissection, the chances of having lymphedema and shoulder mobility restriction is more. We try to do sentinel node biopsy wherever possible. So let's now come to a point where you have planned for a surgery. It's very important that you know what surgery is going to happen, what are the complications which might come out of those surgeries, and what you need to do. So usually you will receive a prescription where the plan will be written, what surgery is planned, and after that there will be certain pre-operative investigation. There will be a set of tests which is needed for anesthesia. You have to make sure that all of them are done properly, step by step, 1, 2, 3, whatever is done, check. You have to meet the anesthetist to get a anesthesia clearance. And in the era of COVID, you also need to do a COVID test. So usually 1 or 2 days before your admission, we ask you to get a COVID RT-PCR done. you get admitted either on the day of the surgery in the morning or the day before. I usually prefer that you get an admission a day before, because then you're all relaxed and all pre-operative workup is done properly if something has been missed out. And usually we ask for a 6 hours of fasting before the surgery is planned. Once the surgery is done, the patient is usually discharged on day 2 or day 3. We have a set of instructions for post-op care. There's another video, you can have a look at it, about what you need to do after discharge. So this is in summary about whatever pre-operative discussions needs to be taken. There's also certain discussions about what complications which we can expect, like lymphedema, or there can be a wound gaping or wound related issues, which again I'll post in a separate video. Thank you, take care, all the best.